In PBC, the immune system attacks the bile ducts in the liver, causing damage to liver cells. It mainly affects middle-aged women and is thought to involve a combination of genetics, environmental factors, and immune dysfunction. The exact cause of PBC remains unknown, but research has uncovered several key factors involved in its pathogenesis. Genetic studies have identified specific human leukocyte antigen, HLA, alleles, such as HLA-DRB1x08 and HLA-DRB1x11, that confer susceptibility to PBC. Environmental triggers, such as exposure to infectious agents or certain chemicals, may initiate an autoimmune response in genetically susceptible individuals. Patients with PBC often present with nonspecific symptoms, such as fatigue, pruritus, itching, and dry eyes or mouth. As the disease progresses, characteristic signs, such as jaundice and hepatomegaly, may become apparent. Diagnosis is usually made based on a combination of clinical findings, liver function tests, and the presence of antimitochondrial antibodies, AMA, in the serum. Imaging studies, such as ultrasound and magnetic resonance cholangiopancreatography, MRCP, can help evaluate the extent of bile duct damage. Liver biopsy remains the golden standard for confirming the diagnosis of PBC and assessing disease severity. Histologically, PBC is characterized by lymphocytic infiltration around the bile ducts, leading to their destruction and subsequent cholestasis. In advanced stages, granulomatous inflammation and fibrosis may be observed. The histopathological findings help guide treatment decisions and assess prognosis. AMA is the most specific serological marker for PBC, present in approximately 90 to 95% of patients. It targets the pyruvate dehydrogenase complex within the mitochondria of biliary epithelial cells. ANA and OSMA are nonspecific markers that can be detected in a subset of PBC patients. Monitoring the levels of these antibodies can aid in diagnosing and tracking disease progression. PBC is associated with several complications, both within and outside the liver. Osteoporosis and vitamin deficiencies are not uncommon due to malabsorption of fat-soluble vitamins. Portal hypertension, resulting from cirrhosis, can lead to variceal bleeding and ascites. PBC patients also have an increased risk of developing hepatocellular carcinoma. Additionally, extrabiliary autoimmune disorders, such as Sjögren's syndrome and systemic sclerosis, can coexist with PBC. The primary goal of treatment in PBC is to slow disease progression and manage symptoms. Ursodeoxycholic acid, UDCA, is the cornerstone of therapy for early-stage PBC. It improves liver biochemistry and delays histological progression. Liver transplantation is an option for patients with advanced disease or those who develop complications. Emerging therapies, such as obeticholic acid and fibroblast growth factor 19, FGF19, analogs, are being investigated for their potential role in the management of PBC. While UDCA is effective in most patients, approximately 30% do not have a complete biochemical response. Genetic factors, disease stage, and duration of therapy are among the factors thought to influence treatment response. Non-responders may have a higher risk of disease progression and hepatocellular carcinoma, necessitating close monitoring and consideration of alternative treatment strategies. Pruritus is a common and bothersome symptom in PBC, affecting up to 70% of patients. Bile acid sequestrants, such as cholestyramine, can bind bile acids in the intestine and reduce pruritus. Antihistamines, such as hydroxyzine, can provide symptomatic relief. In severe cases, opioid receptor antagonists, like naltrexone, may be prescribed under close supervision. Identifying and addressing the underlying cause of pruritus is crucial for improving patients' quality of life. Liver transplantation offers the only definitive cure for end-stage PBC. Indications for transplantation include decompensated cirrhosis, refractory symptoms, hepatocellular carcinoma, or repeated episodes of bacterial cholangitis. The outcomes of liver transplantation in PBC patients are generally favorable, with excellent long-term survival rates. However, complications, such as rejection, infections, and post-transplant cholangiopathy, can occur and require ongoing management. Efforts are underway to develop alternative therapeutic strategies for PBC. Novel treatment targets, including FGF19 analogs and obeticholic acid, show promise in clinical trials by targeting bile acid metabolism and immune dysregulation, respectively. Non-invasive methods, such as serum biomarkers and liver stiffness measurements, are being explored as potential tools for monitoring disease progression and treatment response. PBC can pose unique challenges during pregnancy. Women with PBC might experience worsening of their liver disease and complications, such as intrahepatic cholestasis of pregnancy. Close monitoring of liver function and early intervention are essential to ensure the well-being of both the mother and the unborn child. UDCA is generally considered safe during pregnancy and may be used to manage pruritus and preserve liver function. Living with a chronic illness like PBC can significantly impact patients' quality of life. Fatigue, pruritus, and the burden of medication can take a toll on physical and mental well-being. Multidisciplinary approaches, including patient education, psychological support, and lifestyle modifications, are important for improving overall quality of life. Patient support groups and counseling services can provide invaluable emotional support and help patients cope with the challenges posed by PBC. In conclusion, primary biliary cholangitis is a complex liver disease that requires a comprehensive approach for treatment. Understanding its cause, symptoms, diagnosis, and treatment options is essential for providing the best care to patients. Ongoing research offers hope for improved outcomes and quality of life. Your knowledge in PBC will be crucial in supporting these patients.